Hi everyone. In this lecture, we are going to be starting our discussion on chapter 18, which is moving, handling, and positioning the surgical patient. In this part one of a three-part series, we'll be talking about the transport and transfer of the patient. And so in a little bit, we'll define what that means. All right, so in its entirety, we're going to talk about a lot of different concepts in this chapter. So we're going to break it up into 3 bites so it's a little bit more digestible for us. Okay, so some things to consider, right? We want to know the risks, right? We don't want to just grab a piece of equipment and start using it when we don't know how it works, right? We also want to make sure that we are following HIPAA guidelines and that we are protecting the patient's identity. So let's talk a little bit about what this process looks like, okay? So like I said, we're going to be focusing on transport and transfer. Now, transport refers to how we move the patient about the healthcare facility. So is that with an ICU bed, a gurney, a wheelchair? Are we walking them somewhere? Okay, could be any of those things, transporting them around. Now, transferring them means that we're going to move them from one place to another, like from a hospital bed to a gurney, or most commonly in our profession is from the gurney to the OR table and from the OR table back to the gurney again after surgery. All right. Now, there's different types of equipment, like I said, and we want to know how it works. We want to make sure that we use safety precautions to protect ourselves, our patient, and others. All right. Back to patient identification. Before we take a patient anywhere, we want to make sure we have the right one. All right. So we don't want to transport any patient and we don't want to do any procedure until we have completed the patient identification verification process. All right. Now we're going to use 3 methods minimum to identify the patient. And the most common ones are the chart, the identification band, and the hospital ID number for each patient. So what does that look like? Well, first we're going to check the band, whether it's on the wrist or the ankle. We're going to look for those identifiers, and we're going to ask the person to tell us their name. We don't want to say their name. We want to ask them to say their name, and then we want to ask them what we're doing for them today. All right. If the patient doesn't speak English, we may need to get someone to help us communicate with this individual. Now, the best case scenario is that we plan ahead for this so that we're not scrambling to try to find someone to communicate with our patient. We also want to be empathetic and compassionate to our patient and realize that they're in a scary place. They're in a vulnerable situation, and they could respond in a variety of ways. One of those ways could be by crying or by telling weird jokes and laughing wildly, or, by being angry and being snippy, okay? And we have to give them some grace, all right? So what does that look like, the greeting of a patient? Well, it might go something like this. Good morning, my name is Rhiannon. I'm here to take you for surgery. Can you tell me your name and date of birth? After that, you are going to want to verify the procedure, the location, or side with the patient. So what procedure are you going to be having today? All right. Can you tell me which arm, leg, or side will be operated on? Let's say they're having hip surgery. Can you tell me which hip we're fixing today? Have them point to it. All right. Once we have verified the patient, then we can move on to the transport part, okay? But we always want to think about safety. Safety first, right? Humans are not in nice little boxes. they come in weird shapes and sizes, and they're not asymmetrical, and they're difficult to move about the country. Okay, so, and we can't always hold them close to our body like we could a box, you know, lift with your legs, not your back kind of thing. Accidents can occur, patients can fall, things can get pulled out like catheters or IVs or drains, those kinds of things. So we want to be really careful. We want to make sure that we have enough people to help us if we need help. Don't be afraid to find a buddy to come and help you. All right, so some causes of patient moving and handling injuries. Some of those could be there wasn't enough people. All right, you just simply didn't have enough people to perform the task safely, or the equipment that you need is not available, or it's inaccessible at the time that you need it. Maybe there isn't proper training for the individuals that are helping you, or for yourself. You may feel rushed. Poor communication, feeling tired, all right, and fatigued. All of those things could be causes for patient moving and handling injury. Could also be that there's not proper guidelines in place, or maybe they're just not being followed. The staff is just disregarding those, right? Maybe you're distracted. Maybe you have something else on your mind, or again, you're feeling rushed. You're unfamiliar with the devices that you're using, or the equipment is just in poor condition. It just doesn't work really well. It's old, it's dilapidated, it's antiquated, okay? All of those things could be reasons for injury. So how do we prevent injuries? Well, there are some suggestions that the book gives. The first one is prepare yourself and the patient before attempting to move. Assess the situation, have all the equipment ready, make sure you have enough help. It's kind of the opposite list. Are you seeing that? We didn't have enough help. That could cause an injury. Now we're getting enough help. That could prevent an injury. We're not familiar with equipment. That could cause an injury. Here we're familiarizing ourselves with the equipment. That could prevent an injury, all right? Make sure you use the right equipment for the job. You want to make sure you use proper body mechanics. Position yourself as close to the patient as possible. Communicate with the patient and the team, all right? When you're performing a lateral transfer, such as moving a patient from one surface to the other, you want to make sure that the height is right. Okay, right height. That is going to help to prevent back injuries. You want to, when you're moving vertically, moving a patient vertically, up or down, you want to bend your knees, right? Avoid positions that reduce your base of support, and never try to lift or maneuver the patient with while reaching forward away from your center of gravity, away from your core. Okay, use a transfer device whenever and however you possibly can, right? You never want to take a person, transport a person without the person that is in charge of that person knowing, okay? If you go to the surgical floor to get a patient to help bring them to surgery, you want to make sure that you let somebody know and you check all the boxes before you actually take them, all right? Teamwork and communication are two biggies when we're talking about moving, handling, and positioning the surgical patient. All right, so what does that look like? Well, typically when we get ready to transport a patient, we call. Hi, this is so-and-so. I'm getting ready to come and pick up John Smith to have his laparoscopic cholecystectomy. Is he ready to go? Okay, I'm on my way. I grab a gurney and away I go. All right, I go up there. I get up there. And now I got to go find the charge nurse or whoever I need to talk to that's in charge of this patient. I need to say, hey, I'm so-and-so. I'm here to take so-and-so to the operating room. All right, need to make sure that you get his chart and have all of that stuff with you as well, right? It takes coordination between departments, okay? When you are transferring a patient, again, still, you want to make sure you have the right amount of people. You want to make sure you're communicating with your team and with your patient. Now, some different methods for transporting. Gurney. Also wheelchair. Maybe if they're little ones, they might pull them in a little wagon, or they might carry them. Very rarely do we walk patients to the OR. With C-sections, I've seen it more frequently. Never any other type of procedure, but with C-section, sometimes we'll walk mom back. Of course, she gets a ride out of the place, but we can walk her back to surgery sometimes. So transporting, we're going to use a gurney, some sort of bed, maybe an ICU bed, surgical bed, a wheelchair, a wagon. We might walk them. Okay. For transferring, there's the ambulatory person, all right, that we may transfer from a bed to a wheelchair and back again, lying to sitting and back again, sitting to standing and back again, standing to wheelchair and back again, and then also being prepared for a fall if we are walking with someone, all right, assisting a falling patient or lowering them to the ground safely if they are falling. And then there's that lateral transfer. So we're going to look at those. All right, so our first one that we're going to talk about is transport by gurney. All right, when we are transporting a patient by gurney, and we're going to do this, we are going to transport and transfer each other. It's going to be awesome. All right, so some things we want to remember. Know how our equipment works, know how the gurney works, know how it locks, know how it unlocks, how it steers, how the rails go up and down, know how the OR table works. Okay, we're going to learn all of those things, but you're going to be in different facilities with different flavors of equipment. So make sure you understand how they work before you just make the patient hop on and take them for a ride. All right. The side rails are the most basic. Okay. So when we are transporting a patient, we want to make sure that the side rails are up and in the locked position and they keep all hands, arms, and legs in the moving vehicle at all times. If it is a critical patient, we may need more than just ourselves. We will need more than just ourselves to transport that person. We want to realize that they could have several lines, cords, tubes, wires attached to them. They could have IV, they could have oxygen tubing, they could be on a ventilator, they could have PICC lines, they could have drains, they can have a catheter, all kinds of fun stuff. I want to make sure that we don't pull any of those things out, all right? And most of the time we will hang the IV at the foot. However, in this one, you can see that there's this IV tree that he is pushing behind the patient. Sometimes that happens as well, okay? A safety strap. I don't see a safety strap used too much, honestly, when we're transporting the patient by bed. However, on the OR table, absolutely. So you might be at a facility where they religiously use a safety strap every single time. When we get the patient over onto the OR table, we're going to put a safety strap on 2 inches above their knee, 2 to 3 inches above their knee, and pretty snug. You should be able to get just a couple fingers underneath there. We want to make sure we don't ever put it on their skin, okay, whether they're on an OR table or a gurney or whatever, so that it doesn't cause any abrasions. Okay. Oxygen tank cradle. We want to refrain from just throwing the oxygen container at the foot of the bed or on the side of the bed with the patient. They could get a crushing injury. We want to put it where it's supposed to go, in a cradle or a rack that is specifically designed for carrying that tank so that we don't hurt anybody or it doesn't roll off and smash our foot while we're cruising along, okay? 4-wheel brake mechanism. When you are transferring a patient from OR to gurney, gurney to OR, whatever the case may be, you want to make sure you have the brake on before you move that patient or you tell that patient to move, because that could be a serious fall that could hurt your patient, okay? So you want to know how the brakes work. You want to know how to engage them and how to disengage them. So when you get ready to go, you know how to unlock it. And then there's also another pedal that allows you to steer or be like 4 wheels moving at the same time. If it's in steer, That is designed for a one-person transport. This allows you to push from the head of the bed and control the tail of the bed, all right? If there's more than one person, then taking it out of steer is going to be the best way so that you can manipulate that bed a little bit more easily with just more than one person, all right? And then there's going to be pedals on the bed to raise it up, lower the head, lower the foot, raise the foot, those kinds of things. So be familiar with those as well. We have a gurney in our OR lab. It has all of those things. We'll learn how to use them, all right? There's also moving boards, and we'll look at those in a little bit, all right? So what we're gonna do is we're going to, if we're bringing a patient to the OR, then we're going to bring the patient into the operating room on the gurney, all right? And we're just going to make sure we tell them stay still until we tell you where to go, right? We want to make sure that we have adequate space to move that gurney in. Okay, so we want to think ahead about that. When we're going into a patient room, that could be the case too. Patient rooms a lot of times don't have that much space, all right? We want to align the gurney with the bed that the patient is already on or that the patient is going to, okay? We also want to think about our body mechanics. So if the patient's bed is really high, we might want to lower it a little bit or adjust them so that they're at an even height but safe for our body mechanics, okay? We want to lock the gurney, lock it. Tell the patient not to go anywhere if they're ambulatory, okay? We want to free up all tubings, drainage bags, IVs, wires, all of that fun stuff. We want to transfer it over to the other bed before we ask them to move over. Then if the patient can move on their own volition, we're going to ask them to scoot over, okay? You want to have somebody standing on that other side of the table, right? We wheel the gurney in and one person is standing on the gurney side, at least. Anesthesia is probably at the head. Another person needs to be over on the other side so that they don't just scooch all the way off. They need to be reminded that the OR table is really skinny, all right? And there's a reason for that. That's so that we don't have to lean over a king-size bed to get to the patient. That would kill our back, all right? So a narrow bed facilitates our body mechanics for being able to reach the patient a little bit more efficiently. Once we get everything in place and we lower the side rails and the bed is locked, then we can ask the patient to move over. Sometimes they have some drugs on board, right? They've had a little cocktail, anesthesia gave them. Sometimes they might have to be reminded that they need to use their feet. All right, use your feet, dig your heels in, scoot your butt over to me. All right, one nurse that I used to work with, Ron, he used to say that anesthesia medications turns the lead in your veins or the blood in your veins to lead in your butt. It becomes difficult for the patient to scoot over because they're sleepy. All right, so sometimes we have to remind them, okay, scoot over. Sometimes they might fall asleep halfway. All right, we might have to assist them a little bit. Once they get over there, we want to make sure the patient is secure before we move that gurney away. And somebody needs to be on either side of the OR table, and then somebody else is going to take the gurney away. You do not want to leave your patient unattended once they get on the OR table. That's a big no-no. We're going to put a safety strap over their lap, like I talked about. Usually my spiel is, I'm going to put a little safety strap over your legs to remind you that the bed is really narrow. Then we're going to put their arms out to their sides on arm boards. Again, I'm going to put your arm out to the side where you have a place to rest your arm because the bed is really narrow. Okay? That's pretty much the spiel. I hope that makes sense. All right, here we are looking at our mobile versus assisted transfer to the OR table. Okay, so let's concentrate on the picture on the left first, which says mobile. All right, so let me set the scene. Patient is coming in for surgery. All right, this doesn't look like a real photo. There's no IV, there's no masks on. Looks like it's a setup to me. However, you're gonna get the gist here. All right, so we're going to bring the patient in on the gurney. You can see how the beds are the same height, and you want to align them as well, head to head, foot to foot, the best you can. If the patient is a little bit low in the bed or a little bit high in the bed, you may need to look at the patient positioning as well as the table positioning. So then, once the patient, let's see, I guess as you're moving the gurney in, you're gonna have to put down the side rail on the side closest to the OR table so you can actually get it into position. Once it's into position, we wanna lock it down. We're gonna take down that other side rail. See how there's people surrounding the patient. 2 are on the OR table side, 1 is on the gurney side, there's an anesthesia person at the head side. All right, this is normal. So we're gonna ask the patient, once we've transferred all the lines over, to slowly move over to her right. All right, scooch over to her right. As she scooches over, they're gonna pull that gown out from underneath her. All right, typically our patients don't come in with pants on. They usually don't come in with any of their undergarments on either. All right, they're gonna be covered on with a blanket, typically. We're gonna ask them to scoot over, and as they scoot over, we're gonna help them to maintain their dignity by staying covered, but we don't want them to get that sheet or their gown like tucked underneath them. We don't want them laying on that during surgery because that could cause a pressure injury. And so we're gonna keep that out from under them as they scoot over, okay? I hope this is making sense. So once they get over to the table, again, we need to remind them that it's very narrow, it's gonna be cold, we're gonna get them some warm blankets, we're gonna get them all cozy and snuggly, all right? Once they move over to the bed, then that gurney needs to go bye-bye and somebody needs to come next to the patient at the OR table so that we have people on each side. Next is gonna be to put the safety strap on, and we'll just tell the patient what we're doing as we're doing it. Like I said, I'm gonna put this strap across your lap to remind you that the OR table is very narrow, all right? We're also gonna get arm boards on and get their arms out to their sides. We're gonna be talking them through that the whole time, okay? Then, when surgery is over, typically the patient is too sleepy to move themselves back to the gurney. So we're gonna need to assist them with a lateral transfer, all right? And for the lateral transfer, we use something called a rolling board. Now, hold your horses, it's coming up on the next slide. Bear with me for a second. It takes a minimum of 4 people to do an assisted lateral transfer. What we're going to do is on anesthesia's count, they always control the move of the patient. They call the shots, okay? Anesthesia care provider calls the shots during any movement of the patient. Sometimes the anesthesiologists don't even like you to take the patient's arm off the arm boards until you ask. So have an awareness of this. After surgery, if you're over there monkeying around and you're gonna be moving the patient, you need to get permission of anesthesia first, okay? So here we are. It's time to do the lateral transfer. So we use a transfer board, we get the gurney in there, all right? And then we're gonna gently roll the patient to one side, place the transfer board underneath, and then gently roll the patient onto the gurney. It is like magic. Okay, so here's the roller board in this top, what is that? That's my left. All right, let me mark it. I'm gonna mark it with a green X. Right here, this is the roller board, okay? Now, this is probably about 3 feet long, but they do have 6 feet long ones, but 3 feet ones are usually what we use. We do have one in the OR lab. We will use it to move each other. So usually we put a towel or some sort of sheet over this that we can push and pull with. And this has these rollers inside of it. I don't know if you can see the metal, like shiny metal, like right here. For some reason, my pen doesn't want to circle. These are rollers that go all the length, and then it's covered with this vinyl or whatever that material is. And so this material will roll around the device, will move around the device. Bottom left, right here, I'm going to put an SS for safety strap. This is the safety strap. We put this across the patient's lap about 2 to 3 inches above their knees, and then we snug it down till we can fit 2 or 3 fingers just right between it and the patient. We want to make sure we don't put it over the patient's skin. I'm going to put a blanket there before we put that on. All right. In the top right, this is an arm board with a safety strap. This is not the right way to put the arms. We will learn how to position the patient in the supine position or dorsal recumbent position, and it is very close to the anatomical position. These palms need to be up and then inward, facing inward towards the patient's body just a little bit so that we don't get a brachial plexus injury, and also keeps them off from that ulnar nerve. And then the bottom right. Here we're looking at a hoist. All right, that we can use to move a patient, and sometimes this is what we will use to move those bariatric patients. Okay. Okay, before we move on and talk about wheelchair transport, I just want to say, similar with the wheelchair, when we push someone in a gurney, we want to push them feet first, so that they can see where they're going. The only time that we don't do this is when we are moving into an elevator. When we go into an elevator with a gurney or a wheelchair, we want to back in. That way we're all ready to go when the elevator doors open, and then we can just push out forward, okay? I forgot to mention that, but it's the same for both. So let's talk about some safety guidelines for wheelchair transport. When we transport, this is what we want to do. We want to cover the patient with a blanket. We want to take care to avoid tangling in the wheelchair mechanisms. If they have an IV, a blanket, they have a blanket of their own, their pajama pants, whatever the case may be. We want to make sure that it doesn't get caught up in the wheels or the moving parts of the wheelchair. We want to avoid piling things in the patient's lap. Okay, here, hold this oxygen container. Here, hold the chart. Here, can you hold your barf bucket? Okay, whatever the case may be. We don't just want to pile stuff in the patient's lap. We want to avoid that. Like I said, we want to face them forward so they can see where they're going, except when we're entering an elevator or using a ramp. We want to go up backwards or go into the elevator backwards. When we are transporting patients, we want to use patient elevators if there are some. All right, that's an important thing too. When the elevator car arrives and you can hit the lock so that you can get out, right? And then you can just hit it after you get out. That way you don't have to worry about the door shutting. You know, that always happens. You're like halfway out and the door starts shutting. So if you hit that lock button on the inside, you can get them out safely, and then just quickly hit that unlock button and you're good to go. All right. Again, remind the patient to keep all arms, hands, feet, legs inside the vehicle at all times. All right. And then when you're going down a ramp, you want to turn the wheelchair so the back travels first. This is going to prevent that runaway train effect, all right? Because your body is going to be behind it, like, you know, lowering it down. And we have a ramp at school, so we're going to practice this, all right? When we're moving someone from the bed to the wheelchair, all right, we want to familiarize ourselves with equipment first, check the patient's identification, free up any tubes like we said before, and secure any medical devices that we're taking with us, all right? And then we usually want to use a gait belt, okay? We don't typically do this, and we don't get gait belts as a gift in this program. But a gait belt is a belt that they put around the patient's like upper chest, upper waist area, so that they can help assist them in standing up, okay, or moving over. So some guidelines from a sitting to standing position. We want to be standing directly in front of the patient. We want to place our hands around the patient's torso and under their arms. This is a good place to use that gait belt because you can get a hold of that gait belt and help them up. You want to slightly bend your forward leg to kind of brace yourself as you lean forward to get the patient on that front leg and then kind of rock back a little bit to help that patient stand up. Now, we're standing. Okay, now we got to get into the wheelchair. So to do that, we want to just help the patient take just little baby steps, right? We're going to rotate around and then slowly lower the patient into the wheelchair. Again, by the gait belt, it's really helpful. Spread our feet so we have a good foundation, approximately shoulder width apart, and then use your core, all right, to stabilize yourself. Bend your knees, use your legs, all right? It's all good body mechanics. Make sure you place the patient's feet on the footrest first. Make sure the wheelchair is locked before you sit a patient in it. That's the first thing you should do. When you come in, you park the wheelchair, you're getting ready to transfer the patient into it. Make sure both wheels are locked, all right? Move those little footrests out of the way. You're going to move your patient in. The next thing you're going to do is get their feet up on the footrests, cover them up. If there's a safety strap, you're going to use that and secure that. And then make sure you have all your records and your goodies. Unlock the wheelchair and you're off to the races. Now, if we're going from a wheelchair to the bed, it's basically the same thing. We want to lower the bed as low as it will go so that it is easier. All right. So then we're going to use the reverse steps and we're going to get them standing up, transfer them over to the wheelchair. A lot similar to what we just talked about before. All right, moving on to assisting the ambulatory patient. Yes, they can move themselves. Easy for us, right? Until they get a little woozy, all right? And then that could be dangerous. We want to position ourselves slightly behind the patient's shoulder while helping them walk. Look at this image on the left. That is a good example, okay? If the patient becomes weak or woozy or whatever, you want to use that front leg to support and brace yourself with that front leg. Take a little step forward and allow the patient to kind of slide down in a controlled fall. You don't want to try to stop them from falling. You're going to hurt them, yourself and them. All right, so just allow them to slowly and gently ease them to the ground, okay, and then into a lying position. Cover them, get help, okay? Cover them and get help. All right, now a little bit about special patient populations. All right, let's first talk about the pediatric patient. If you've seen a jail cell, or you know what one looks like, there are these cribs that we can transfer the pediatric patient in that kind of looks like a little jail cell on wheels. And this is just to prevent them from falling out or crawling out or anything like that. They could also be transported by a gurney, a crib, a bassinet. It depends on how old they are and what is going on with them. All right. Remember, they're going to be really anxious, and if they're fairly young, they're going to have separation anxiety from their caregiver. All right. Sometimes we do allow them to accompany the infant or toddler into the operating room. They can carry them in and just walk them back, and they can stay there during induction, and then once the little one is asleep, then they can sneak away. All right. If the child is unaccompanied, that's going to be really stressful for them. like I said, especially toddlers and preschoolers. So you want to talk with them, maybe a little bit of distraction is good, all right? Remember, children ages 5 to 9-ish are really curious about their environment. They want to know what's going on, all right? You use simple verbiage and tell them without scaring them. Preteens, they want to be part of their care, right? Teenagers are likely to seem unconcerned, but they do appreciate explanations regarding the environment. And you don't want to treat a child like a small adult. They're not adults. Provide a calm, supportive presence, show respect, all right? But don't placate them, right? Instead of saying, oh, don't be afraid, it's going to be okay, it won't take long, you know, evaluate the child's understanding and tell them, you know, be honest with them, but, you know, don't overgive information. And like I said, sometimes distractions are good. If you're moving along and there's pictures on the wall, or a lot of times in the pediatric wings of hospitals or Phoenix Children's Hospitals, they get a teddy bear, or there's, you know, balloons or rainbows on the wall. Who knows? Maybe that could be something that could offer a distraction as well for the little one. All right. Hearing or sight impaired patients, disabled patients. Let's talk about them for a bit. When we're transporting a patient that has hearing or sight deficit, it might take more time and more supportive personnel to achieve a safe transport. All right, slightly impaired patients might be able to communicate verbally. However, if they're also hearing impaired, we may need some sort of interpreter, right? Somebody that can do sign language. When transporting a hearing impaired patient, we want to let them keep their hearing aids as long as possible and use hand gestures to communicate as much as we possibly can, all right? We want to speak slowly and articulate our words well. Speaking up is okay. We don't want to yell at them, all right? We want to face them when we are having communication with them. Now, in the operating room, that's a little bit, it's not difficult to face them, but our mouths are covered, so it's going to be difficult to read lips in that situation. So hand gestures are going to be a good thing, all right? If they're sight impaired, we want to let them keep their glasses as long as possible, and we want to explain, we want to over communicate with these visually impaired individuals, okay? Now, bariatric patients. Bariatric patients, they are defined by the body mass index, all right? Mildly obese individuals have a BMI of 27 to 30, and those that are considered obese have 30 BMI or more, okay? Transferring and transporting them, you are going to need more people. You may need more specialized equipment, okay? They might not be able to breathe very well. You might have to think about positioning of the bed when you're transporting them so they're not laying flat on their backs, okay? They could suffocate from the weight of their own self pressing back on their thoracic cavity, okay? Some other challenges from an anesthesia care provider perspective are their lack of flexibility in their neck. It's really hard to find those landmarks that we typically use to indicate where we are, right? It's like those landmarks, those bony prominences of the body are kind of like our topographical map, all right? And so with obese individuals, it's hard to identify those structures that typically help us to get our bearings, all right? We're going to need a special gurney. We're also going to need a special bariatric operating room table. There are also special weight-bearing wheelchairs that we can use, and special pieces of equipment that we use to move the patient if they are not ambulatory. We're also going to have to think about the blood pressure cuff. We're probably going to need a larger size. And if we're using some sort of pneumatic tourniquet, we're probably going to need a larger size of that as well. Not to mention what's going to happen intraoperatively. We may need to make sure that we have extra long instruments and extra long devices to use intraoperatively as well. Patients in police custody. I actually have had quite a bit of experience with this. Working at the Casa Grande Hospital, the Eloy Detention Center is just a hop, skip, and a jump away. And so we had several patients, inmates, that came for hernia repairs or whatever the case. And I think maybe one had a ruptured appendix at one time or whatever. And so that's definitely a thing too. They're usually accompanied by correctional officers, usually a couple of them, and sometimes one of them will accompany them into the OR. They usually put a leg cuff on the patient and cuff it to the gurney, and then they'll need to remove that to have the patient slide over onto the OR table. So communication with them is really important. Usually they don't hang out. We have them step out as soon as we get the patient moved over, and they kind of stand guard, if you will, at the operating room door until we're done. All right. All right, so here's our picture of our pediatric patient. I already talked about them, but you can see this crib that does kind of look like a gel cell to me, to keep them from rolling out or falling out or crawling out or whatever. And then I mentioned the little red wagon, and so you can see that here. All right, I spoke about our hearing or sight impaired, right? We want to make sure that we give them the dignity and the respect that they need to keep their devices as long as possible and take the precautions so that we can communicate with them and meet them where they're at. Here are some positioning devices for the bariatric patient. You can see this inflatable slide that they're using to move this gentleman from one bed to the other. And then here you can see the patient on this special bariatric bed, and they have these little foot extensions at the bottom to keep the patient from falling off the bed. All right, and then our patients in police custody, like I said, sometimes this will happen. The correctional officer, you can expect them to need to come into the operating room. They'll be dressed out, or they'll have on like a cover-up suit and a bonnet and a mask and some booties. And they'll come in, they'll unlock the handcuff from the rail, and then they will wait outside. And as soon as we move the patient over, then they will come back in and they will reattach the cuffs to the patient and to the gurney. So what is our role? Well, we need to make sure we're familiar with the stuff that we're using. We want to be proactive. All right, it's not just the circulating nurse's job to go and get the stuff that we need to position our patient. So help out. All right, ask the circulator, what can I do? Can I grab the stirrups? Can I grab the positioner for the bed? Can I get whatever? Right, be proactive, think ahead. All right, especially if you're familiar with what the surgeon and what the surgeon uses, but you're with a nurse that you know doesn't work with that surgeon. All right. Understanding each position and associated devices, very important, all right? What position goes with what procedure, and also surgeons' preferences do matter sometimes, and what devices we're going to need for that. And if you don't know, ask, get clarification, and over-communicate. And lastly, stay focused and alert, all right? It is everybody's responsibility to make sure the patient is safe, so that includes moving, handling, and positioning. So if you see something that's wonky, right, don't just be asleep while the patient's, be oblivious while the patient's getting moved and transferred and positioned and all of those things. If you see something, say something. Okay, you're an advocate for the patient as well. Okay, so That brings us to the end of part 1, talking about transport and transfer. So I hope this brought some clarity to this first part of talking about moving, handling, and positioning. Thanks for listening.